Continuing education credits for physicians and other healthcare professionals are provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information. The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed in this podcast are solely of those of the hosts.
Welcome back to the Cribsiders. I'm Chris the Chi Manchu. I'm joined tonight by multiple people, including my co-host Sam. Say hi.
Hey.
And Jennifer and Prachi. Hey guys.
Hey, happy to be here.
Hi.
And it's Prachi's first producing episode, so we're excited to have her here. Sam, before we get into the show, do you want to remind us what this podcast is all about?
I'd be happy to. So we are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring clinical pearls, practice-changing knowledge, and answering lingering questions about core topics in pediatric medicine.
We have a fantastic conversation with our guest, Dr. Michelle Perez. She is a pediatric intensivist, fellowship program director, and New York Times game addict. She is an associate professor at the Children's Hospital at Montefiore in the Bronx, New York. Her research interests include using simulation as a quality improvement tool, help disparities in the ICU, and respiratory failure. In her free time, she enjoys hiking, craft beer, and traveling with her family. Today, she teaches us the fundamentals of respiratory support, including high-flow nasal cannula, NIV, BiPAP, and CPAP.
Hey, Chris, I was wondering, are you feeling anxious when you think about all the different types of respiratory support and everything you need to remember?
Absolutely.
Well, this is the episode for you because there's absolutely no pressure and there's just support.
Oh, I like that. I like that.
Yeah, that's good.
That's a good
I like
one.
it.
Yeah. We'll give that 2 thumbs up.
Hello, Dr. Perez. Thank you for coming on the show.
Thanks for having me.
First, because we're sort of an informal group, I'd like to ask, is it okay if we go by your first name?
Of course.
All right. So that's Michelle, correct?
Correct.
All right. So we're going to start off with some, rapid fire warm-up questions, just so that our audience gets to know you a little better. So would you be able to give us a little one-liner to describe yourself?
Sure. So I am a pediatric intensivist at the Children's Hospital at Montefiore. I am a medical educator. I run our PICU fellowship, and my research interest is in using simulation to improve emergency readiness. I live in the suburbs with my wife, who's also a pediatrician, and our son, who's almost 2.
Excellent. I love simulation so much. So I was active duty in the Air Force for several years, and we did a lot of sim. One of the best advice I've heard was from an ED physician, and he once said that when stuff hits the fan and things are really difficult, that you never rise to the occasion. You fall back on your training, and that's where sim really saves us. So I really love that. That simulations serve where you live, and that this is your area of education.
So, Dr. Perez, we wanted to ask you, what's the best advice you ever received as a learner, as a teacher, or in your career?
So I think as a learner, the best advice I ever got was just to be curious about everything. It's really easy to go through the day and be focused on getting your orders in and getting your notes done. But what's a lot more important is being at the bedside and asking questions about changes in patient status, why things are happening, and if people are making decisions, what the reasoning is behind that. I think this curiosity really extends to the whole team. And so if 2 attendings or 2 people in the staff are having a conversation about your patient, that's a great time to just listen to their reasoning and to the thought process, which is going to help you go forward and create your own thought process. And in the ICU, that really extends to the nurses and the respiratory therapists. Just kind of being present and asking questions is how I learned so much of what I do every day now.
Excellent. Jen, do you have any questions you want to ask before we jump into the rest of the podcast?
Yes, I always love hearing from people further along than me as a resident about what your favorite failure was.
Sure. So I have one that's kind of silly. It seems silly now, but when I was a in my first week of fellowship, we had a patient who was pretty sick, needed to be intubated, and I was super nervous about it. And I successfully put the tube in on the first try and was really proud of myself. And then every time we connected to the ventilator, everything didn't work. And my attending and I troubleshot. We went back, we did it. I ended up taking the tube out, putting a new one in about 3 times over. And at the end, a more senior attending popped by and realized that something was disconnected. A piece of plastic had popped off the ventilator. And in the moment, we all felt really dumb. But I think what I learned is that when something doesn't go the way you think it should go, it doesn't make sense to just keep doing that same thing over. And now whenever I find myself in kind of one of those weird moments where you have no idea what's going on, I sort of really try to take a step back and reframe the way I'm looking at the situation.
Also, what I take from that also is, reach out to some of your friends, some of your colleagues, and sometimes more heads help to sort of troubleshoot the situation, or so an outside observer can come in and be like, all right, what's going on here, and help us out in those types of situations.
Yeah, definitely. Sometimes you're in the middle of it and you don't even realize you haven't, checked your first box.
Awesome. We get a lot of stuff going on here. We have an awesome case. I'm actually really excited about this. It's hopefully going to help me in my practice. So Prachi, if you wouldn't mind just reading the case for us, and let's take it over to Cashlight Children's Hospital. Hey, Cribsiders listeners. On episode 135, we sat down with Dr. Tristan Nichols and talked about how AI is already changing how we practice pediatric medicine. From expanding differentials on tough cases to generating discharge instructions that families can actually understand. One thing that really struck with me is the idea that AI shouldn't replace our clinical reasoning. It should sharpen it, and that's exactly why I've been using Claude. Claude is the AI for minds that don't stop at a good enough. It's the collaborator that actually understands your entire workflow and thinks with you. Whether you're debugging code at midnight or strategizing your next business move, Claude extends your thinking to tackle the problems that matter. What I love about Claude for Medicine is its deep research capability. It goes way beyond a basic web search. I'm talking comprehensive analysis with proper citations, pulling connections across dozens of sources that I would never spot on my own. It's like having a research partner who never gets tired. Whether it's working through a tricky inpatient diagnosis, reviewing the latest management guidelines, or putting together a teaching topic for my residents, Claude helps me think deeper instead of just skimming the surface. So Cribsiders listeners, ready to tackle bigger problems? Get started with Claude today at claude.ai/Cribsiders. That's claude.ai/Cribsiders, and check out Claude Pro, which includes access to all the features mentioned in today's episode. claude.ai/Cribsiders.
Okay, so the case. Aria is a 1-year-old, previously healthy female brought into the emergency department by her parents, who report she has been struggling with nasal congestion, decreased oral intake, and increased work of breathing for 3 days, and now worry that she is having difficulty breathing. She has associated fevers and fewer wet diapers over the last 24 hours. Temperature of 102.1 degrees Fahrenheit, pulse ox of 88% on room air, respiratory rate of 60 breaths per minute, and heart rate of 130 beats per minute. She has nasal flaring, subcostal and intercostal retractions, indicating acute respiratory distress. Aria continues to have significant respiratory distress after supportive care with suctioning and saline nebulizer, and the decision is made to start her on high-flow nasal cannula. So to start us off, could you give us a quick 101 overview of why a child would need more respiratory support than being just on room air?
So the most common reason a child needs some extra respiratory support is due to concern for either respiratory failure or impending respiratory failure. So this patient has some findings on exam that show me that there's high risk of respiratory failure. She's tachypnic, she's retracting, and hypoxemic with a pulse ox of 88%. And what's really important to note is that these symptoms are persistent, even though there's been attempts at airway clearance and suctioning. And so we know that this is a problem that's not going to go away with one of our easier solutions. In peds, respiratory illnesses are the most common cause of both hospital admissions and ICU admissions. So this is something we see very commonly. Infections are the most common cause. You can have airway infections like bronchiolitis, pneumonia, upper airway infections like croup, or you can have infections that exacerbate more chronic conditions like asthma or BPD. So in these cases, patients can either be supported with traditional nasal cannula, or they might need non-invasive ventilation, which can help to augment oxygenation, ventilation, or both.
Awesome. So maybe we'll start there. Let's start, you mentioned non-invasive ventilation and nasal cannula. I think for this conversation, we'll say, hey, we know what nasal cannula is. What are our non-invasive support options? What are those things? What are those? And is high-flow nasal cannula considered one of them?
So non-invasive support uses either a mask or a cannula to deliver positive pressure to the airways, assisting breathing. And it can provide both oxygen and pressure support. So the different options are high-flow nasal cannula, and then BiPAP or CPAP. So in this case, you brought up a good point, is high-flow nasal cannula even positive pressure, even non-invasive ventilation? So there's a lot of misinformation in pediatrics about high flow, especially as it's become more and more prevalent. So I think it's a great thing for us to talk about today. So high flow delivers heated, humidified air at high flow rates via a soft silicone nasal cannula that fits in without occluding the nose. So it's not a closed system. And you can adjust the oxygen content and the airflow rates. So the reasons we think this is helpful, the biggest reason, especially in small kids, is that high flow allows for reduction of the dead space of the upper airway. So dead space is space that's filled with air but doesn't contribute to oxygenation and ventilation. And in small kids, anatomic dead space is larger proportionally than it is in bigger kids. So high flow allows you to wash out this dead space and replace it with oxygen-rich air. It also can provide a constant flow of FiO2 and doesn't allow room air to be entrapped. And then the warm air really minimizes airway irritation and improves comfort. And so heated, humidified air has been associated with less bronchospasm, less energy expenditure with breathing, and improved mucociliary clearance. Traditionally, non-invasive ventilation is thought it was defined as something that provides positive pressure. And high flow was thought to provide positive pressure through some low level of PEEP. In most studies, that hasn't held up very well. In animal models, you can see a PEEP reached 6 to 7 with the mouth closed. But as soon as the mouth closes, a lot of that pressure is lost. And so high flow certainly provides some ventilatory assistance, but whether or not it's strict non-invasive ventilation and whether it provides any positive pressure isn't really figured out one way or the other, and is probably more towards a no.
So one question I have, you've used a couple of terms that, some of our learners who are earlier in their education might not be completely familiar with, but they know they're associated. So you talked about ventilation, and we've been obviously also talking about oxygenation. Can you sort of describe what the difference is and how what you're talking about when you're saying FiO2 versus you said something like PEEP. So I know there's not going to be like a full lecture on this, but I do think that these sort of subtle terms sort of need to be teased out a little bit before we continue to move on.
Yeah, of course. So oxygenation is the delivery of oxygen to the lungs. This is determined mostly by mean airway pressure. And so PEEP, or positive end expiratory pressure, is one way of increasing the mean airway pressure. You can also adjust the amount of oxygen a patient receives by adjusting the fraction of inspired oxygen. So their FiO2, you're able to give them more than 21%, which is what we breathe in room air. Ventilation refers to the actual size and frequency of breaths. And so in lab results, we see this as CO2. So retained CO2 means not enough ventilation. And you can adjust ventilation by either making breaths larger or more frequent. And so in non-invasive ventilation, the way to do that is by providing more inspiratory pressure.
Okay, that was really helpful. And I have to say, I think as a trainee, it's easy to see all these terms and not really understand the underlying concepts. So it's really helpful. I was also wondering along those lines, in terms of kind of big picture fundamentals, can you tell us about the other kind of options in terms of non-invasive respiratory support? And big picture, what would make you lean towards choosing, for example, high flow or some of the other options like NIV or BiPAP?
Sure. So we talked about high flow a little bit. The other most commonly used options are probably CPAP and BiPAP. CPAP is continuous positive airway pressure. So one constant level of positive pressure that's applied throughout the inspiratory and expiratory phases. So this really helps to improve your mean airway pressure. It can help to allow for prevention of atelectasis and will help support oxygenation problems. It's not going to really help make your breaths larger or more frequent. BiPAP is bi-level positive airway pressure. So here you set 2 levels of support. You set one level during the inspiratory phase. That's called the IPAP, the inspiratory positive airway pressure. And one level during the expiratory phase called the EPAP, the expiratory positive airway pressure. The difference between the IPAP and EPAP provides driving pressure for each breath. So in general, CPAP can help you with your mean airway pressure and improve oxygenation, while BiPAP is able to do both, help with your mean airway pressure as well as provide support to each breath. You mentioned NIV as different from BiPAP and CPAP and high flow. So NIV can be an umbrella term for all of these, but there is non-invasive mechanical ventilation, which is basically the option of delivering full ventilator level support through a non-invasive interface, meaning a mask or nasal cannula. And that allows you to set not only pressures, but also respiratory rate and oxygen delivery, as well as an inhalation time and an exhalation time. The issue with that is in large kids, it's often very hard to appropriately deliver that amount of support just because the mask needs to be able to sense their respiratory effort. And so it's used most commonly in the NICUs in very small babies.
So let's take ourselves a little bit through this case, and then I do have one more physiology question, but I do want to kind of move us a little bit. So you're saying, hey, this kid is in some sort of impending respiratory failure, whether you define it as respiratory failure or impending respiratory failure, and that is a concern for us. Is there anything that we should know about why we should initiate high flow nasal cannula in this case? Or is it just as simple as, hey, this kid's impending respiratory doom, I would like to do something more than room air, and so we start at high flow nasal cannula? How do you generally approach that?
So I generally approach it as if what we're worried about is hypoxemia or a little bit of work of breathing, I think it's very reasonable to start with standard flow oxygen. And most of the data that shows high flow is helpful shows that's helpful in patients who have failed regular low flow oxygen. So in this patient, you could start with your supportive measures. You could make sure there's no fever, that chest PT has been done, and you could start with some low flow cannula. And it's possible that their saturation would improve and their work of breathing would get better with the airway clearance. It's really important in these patients to have some kind of objective assessment of work of breathing, because if you take a 6-month-old broncholytic and you ask 5 people to tell you how severe their work of breathing is, you'll often get 5 different answers. And so most institutions have some respiratory scoring system that they use, and that usually includes things like heart rate, respiratory rate, and findings on exam. But when you can communicate with other providers and staff using objective measures, then what we find is that you're much more able to speak the same language and to communicate improvement or worsening more effectively.
So what type of objective measures do you normally sort of agree on with your staff when you're looking at a patient?
So for sure, degree of tachycardia and tachypnea. And so if you tell me the patient was tachypnic to 70 and now they're, breathing 40 or 30, that's better. Tachycardia, especially in infants with bronchiolitis, are always unhappy. They're always not sleeping well and febrile and miserable. And so if their heart rate has come down a lot and they look more comfortable, that's great. And then, most of the scoring systems include retractions, the degree of retraction where you're seeing them, as well as difficulty feeding, difficulty vocalizing, and then degree of wheeze. So do you have normal breath sounds? Do you have inspiratory and expiratory wheeze, et cetera?
What are the most common validated scoring systems or tools that we might see out there?
So there's the Seattle respiratory score is probably one of the most common bronchiolitis scoring systems, but some people use Pew scores, which is the pediatric early warning system, which isn't really tailored towards bronchiolitis, but can also be used. I think as long as your institution is consistent, they're effective.
I agree. So I feel like every provider has their own style of treating patients. So it's nice to know that there are objective measures and scoring systems that we can use. So kind of just going along with the case, how do you determine the flow in FiO2? And what are specific indicators to guide adjustments in the high flow nasal cannula flow or FiO2?
We've all been there. You walk out of a patient's room and need a focused differential and management plan now. Sanford Guide, known around the world for its much-loved antimicrobial therapy guidance, has covered you with a new app for pediatric acute care. There's no need to find an empty workstation. On your phone, you can search over 500 pediatric acute care topics in seconds. What you get isn't bulk or filler, it's streamlined, clinically nuanced guidance that's continuously updated by experts from the leading children's hospitals. This isn't an encyclopedic reference to scroll endlessly, and it's not an AI-generated summary. Every topic is intentionally written in a succinct, high-yield format from the start. So the Sanford Guide to Pediatric Acute Care app gives you exactly what you need at the bedside. Clear diagnostic reasoning paired with practical, evidence-informed therapeutic guidance. Search for Sanford Guide in the app stores, and Cribsiders listeners can get 20% off the already very moderately priced yearly subscription directly from sanfordguide.com. Go to sanfordguide.com and use the code Cribsiders at checkout.
There's evidence that high-flow nasal cannula works best at a flow of at least 1.5 liters per kilo per minute. Most institutions will start either at 1.5 or 2, but data doesn't really show a significant difference in those two. There's a higher risk of treatment failure if you start at less than 1.5 liters per kilo per minute. So in general, I would start at a flow rate of 1.5 liters per kilo per minute, and then I would look at my objective score. And if the patient was no better or was getting worse, I would consider escalating to 2 liters per kilo per minute. There's not much data that says anything above 2 per kilo is helpful, and so that would usually be my cap. In terms of the FiO2, I would adjust that to maintain a goal sat of somewhere between 88 and 90%. Unless there was something special about this patient that made me more worried about hypoxia. For example, they had altered mental status, poor urine output, lactate elevation, something that's showing me systemic shock that I think they might need more oxygen for some reason.
Can I ask a stupid question? So, when I use regular nasal cannula, I think of liters per minute and it goes like 1 liters per minute, 2, 3, 4, 5, 6. And then, so where does like high flow at 1 per kilo per minute fit? And then what's it a kilo of? Are we titrating for the size of the child, or is it kilos of something else? It's been a while since I've done some inpatient peds, so I apologize if that sounds like a stupid question.
No, it's a great question. So everything's weight-based. And so for a baby that's 4 or 5 kilos, then 1.5 comes out to 7.5 kilos per minute of 7.5 liters per minute, of oxygen flow. So high flow, it's in the name, but obviously much higher flows than your traditional nasal cannula.
I have another question that might sound like a stupid question, but as a resident, I see high flow used a lot for children with bronchiolitis, and I don't see it as commonly for other respiratory pathologies. Why is that, and what would make you up towards wanting to use high flow as an initial option in terms of support?
So high flow is most helpful in bronchiolitis because it has a few benefits that tailor specifically towards that population. So those are smaller kids who have more dead space than larger kids, and who that washout is helpful. They're also children with a lot of secretions, and so helping to clear the secretions can be very helpful, and helping to make them comfortable with the warm humidified air is also helpful. In larger kids with respiratory failure, high flow may not be as helpful because it doesn't deliver much pressure to those populations. And those kids are often have more primary lung pathology than an issue with secretion clearance or work of breathing. And so there are some patients who I would consider high flow. For example, a larger kid with pneumonia who needs oxygen support, maybe more than he can get from 2-3 liters of nasal cannula, but isn't having a lot of work of breathing, doesn't seem like he needs too much pressure, just needs a more efficient way to deliver oxygen. Or sometimes kids who have a lot of trouble with secretions and need frequent suctioning, and you worry that putting a fully occlusive face mask on them might make it impossible to suction them appropriately. Those are kids that I would give a trial of high flow to.
I do want to talk a little bit more about dead space washout because I feel like when I was in residency, I always got to dead space washout and then just nodded along and forgot to push a little bit past that to understand what's going on when we talk about that. So the first thing is that we are increasing flow, right? 1.52 liters per kilo to try to get what we presume to be more flow to the area to wash out that dead space. So my question is, why does that matter? And number two, what's the concept behind this? My guess or my understanding is that we are just putting air that's closer to our alveoli. But is there anything more complicated than that? How do we really explain that to people like me? And then why does the flow actually matter?
So exactly as you said, the dead space is filled with air that really isn't participating in oxygenation and ventilation. And so in infants, they're using a lot of work to move that air out of the way, to take in a new breath, to get more oxygen-rich air. And so if you can sort of wash out that air that has already had its gas exchange and is just sort of hanging out there, you can make their work of breathing a little less because they don't have to worry about turning over that piece of air. Bit of an oversimplification, but
yeah, no, that's perfect. We're good about oversimplifications. That's what we're going for here. Try to take something complicated and make it simple for us. But why does the amount of flow change that? For example, I can picture how the amount of flow could change the PEEP in the sense that you are providing more air in an area in a certain minute, but that I don't understand why that changes the amount for the dead space washout.
Because you're trying to have at least as much flow as your peak inspiratory flow. And so you want to match, this patient's working very hard to breathe and they're trying to take more and more air. So you want to take as much of that away as you can, where like 1 liter per minute of regular oxygen probably would not provide enough of that percentage.
Oh, gotcha. So they're working so hard. So I'm gulping in, we'll say I'm increasing my, inspiratory volume to, 200 milliliters. And so therefore I need at a higher flow. So essentially that much more to take away that extra work that I'm putting in. Is that, again, another oversimplification that summarizes it?
No, that's good. Yeah.
Okay. All right. Sweet. Perfect. All right. So I feel like we're doing pretty good on high flow nasal cannula. Yeah. We kind of talked about doing the kind of objective monitoring. Yes, this objective monitoring is based on vital signs, based on what we're doing, an increased work of breathing, but we're giving an objective score for. So I imagine that's how we're monitoring this for both worsening or improvement. So I think we should continue on with the case and see how things are going, and take it from there. Let's see if things are getting better or worse for our patient.
Of course. Okay, so Arya is started on high-flow nasal cannula support at 2 liters per kg per minute, with FiO2 titrated to maintain oxygen above 92%. Her PCR is positive for RSV, and her chest x-ray does not show any consolidations. Arya continued to have worsening retractions, grunting, and desaturations to low to mid 80s, overall appearing fatigued and at risk for respiratory failure. Blood gas analysis showed a pH of 7.28 and a partial pressure of CO2 at 60 millimeters of mercury. Can you talk us through what your thoughts are about those numbers and what your approach would be for next steps?
Yeah, so we have a lot of information here. We have some information that's helpful diagnostically. So we know she has RSV, and the x-ray tells us there's not something like a large lobar pneumonia or a pleural effusion that's explaining her hypoxia. So that really puts us in the bronchiolitis category. I worry about the retractions and grunting and especially the desaturations to the low 80s. in this patient who's already on supplemental oxygen through the high flow nasal cannula circuit. Is this an arterial or venous blood gas? Do we know?
We're going arterial. He did a really good job.
I love it.
RT did the stick. I didn't do it because I'm not good at them. So.
So on an arterial blood gas, the pH should be between 7.35 and 7.45, and your PCO2 should be between 35 and 45. So here we see an elevated PCO2 and we see a low pH, which is consistent with a respiratory acidosis. I can tell you that for every 10 millimeter of mercury change in PaCO2, your pH should change by about 0.08. And so here your PCO2 has risen by 20 and you have a pH of 7.28, which is pretty close to the 7.24 you'd expect. And the reason that's important is because it tells you don't also have a concurrent metabolic acidosis that you need to worry about. Typically, kids with bronchiolitis can show a lot of increased work of breathing and still have a normal SAT and blood gas. So in this case, the severe hypoxia and the respiratory acidosis would really concern me.
I have a question that's another going back to basics kind of question relating to what you just said. So, we know in this case that the child is quite sick. And I was wondering, circling back to a term you used before, respiratory failure. Can you remind me what the difference is between respiratory distress and failure and how what the definitions are?
Respiratory distress, acute respiratory distress, is a term that describes clinical findings. So this is a patient that you have a clinical concern as having difficulty breathing. You might see tachypnea, accessory muscle use, retractions, difficulty speaking, things like that. Acute respiratory failure is an actual finding that reflects the lungs' failure to maintain adequate gas exchange. So for hypoxic respiratory failure, this is defined by a PaO2 less than 60 or a SAT less than 88% on room air. For hypercarbic respiratory failure, it's defined as a PaCO2 of greater than 45 or an arterial pH less than 7.35 and an arterial pH less than 7.35. But as we alluded to with our excitement about the arterial blood gas, we don't always have this information in pediatrics. And so sometimes, especially for the hypercarbic part of it, we have to make a bit of a judgment call. And that's okay, but that's the reason why objective findings are really important. And in this patient, with all these desaturations, the blood gas is a great piece of information to have, but it doesn't really change anything because I know this is a sick kid already.
So this child has, well, in the first part of the case, we already had some component of hypoxic respiratory failure, but we didn't really know if they had some hypercarbic failure. And as you said, the gas didn't really help you too much more than already knowing that this patient was already sick, and we're already doing some bit of ventilator support. Like, at what point should we be pushing to get that gas if it's not helpful or helpful? And at the same time, we did get this arterial. At some point earlier, it's possible that as the child's sick, we start an IV at some point and we're able to get some blood. At what point would a venous gas at least be useful in the whole situation?
Yeah, so I think pulse ox is a great invention, right? So we have a constant evaluation of our saturation that can help us with the oxygenation piece. In bronchiolitis, respiratory acidosis is definitely concerning, but is often something that you can see on your exam. Kids are working really, really, really hard. And in fact, they may be having periods of time where they appear to have apneas or less consistent work of breathing, which is something I worry about in this patient who all of a sudden has desaturations and then comes back up. So much of what you're worried about in terms of ventilatory failure can actually be seen on exam in this population. Once you start talking about using a non-invasive ventilatory support, it is sometimes helpful to have a blood gas because you can do a lot with a BiPAP machine. And it is helpful to know if you're giving more and more support and your patient is just getting worse and worse, that you may want to go to intubation and not continue down the road you're on. There are, in some PICUs, transcutaneous CO2 monitors, which can also be really helpful in this situation and prevent the arterial blood draws.
Hey, Cribsiders listeners, whether this is your first episode or you've been with us since day one, you know our goal has always been to share real wisdom about practicing medicine. So let's talk about something that actually changed my day-to-day as a hospitalist, and that's FIG scrubs. I can't walk into a clinic or hospital without seeing people in FIG scrubs, and I get it, I wear them too. They're incredibly soft, form-fitting, and durable, and it's not just dust. If you've been watching a certain popular ER drama on TV, yep, they're in FIGs too. These scrubs get it. That's what drew me in and what keeps me coming back. And because we work with kids and kids come with messes, I love that FIGs are antimicrobial. When stuff gets on your scrubs, and it will, you just wash them and they come out wrinkle-free. I've washed mine well over 50 times and they still look brand new. All of that and so much more is why we've teamed up with FIGs. Now, Cribsiders listeners can get 15% off. Just go to wearfigs.com and use code FIGSRX. That's WEARFIGS.com and use code FIGSRX for 15% off. So I'm going to kind of take us to the next portion here, which is, all right, what are we going to do? So this patient, we just gave this case with a, blood gas with a 72860 and definitely looks poor. What are your next steps for Aria right now?
So at this point, I would reach for a higher level of support. And so you could think about CPAP or BiPAP. We talked before about CPAP being a better tool for pure hypoxia. And in this case, we have hypercarbia too. So I think this is probably a person where I would go straight to BiPAP. Generally, when you're using these modalities, you'll have a respiratory therapist around. And so it's helpful to have their involvement. But you really want to understand how to decide the settings and how you assess what work the ventilator is actually doing. And so if we were to trial CPAP here, you would set one continuous positive airway pressure. You would typically start around 5. But if the patient remains hypoxic or has an x-ray showing poor lung expansion or an exam consistent with a lot of atelectasis, you might go higher. And that can help keep the alveoli open and improve oxygenation. In BiPAP, again, we said you set the 2 levels of support, one for the inspiratory phase and one for the expiratory phase. And then in infants, you can the typical starting settings are an EPAP, expiratory pressure of 5, and an IPAP, inspiratory pressure of 10, which gives you a driving pressure of about 5. One of the major issues with BiPAP is that the machine and mask can be very uncomfortable. So often people will start lower and just sort of stand there and slowly accustom the patient to the pressures. And then once the patient is on the machine, you want to look at the machine to see how much volume the patient's getting. So you remember that compliance is the change in volume over the change in pressure. And so when we set a pressure, the lungs' intrinsic compliance determines how much volume they'll get for that pressure. So a patient with really severe lung disease may get much less tidal volume per breath than a patient with healthy lungs. And so you want to target a tidal volume of about 6 to 8 cc's per kilo. And you should really try to stay below 10 cc's per kilo to prevent trauma from the high volumes.
Awesome. We kind of had an episode on ARDS where we did talk a little bit about volumes per kilo and trying not to cause certain types of pressure like baropressure and volume pressure, and the other one that now is escaping me from my brain right now. But the 3 types of problems that we're trying not to cause. Mm-hmm. Let me ask you quickly about the CPAP versus BiPAP situation. It sounds like BiPAP is going to get us what we need from a ventilatory support standpoint, but we don't actually know that some of our issues aren't all related to atelectasis, for example. Our tidal volumes aren't decreased because whatever's causing our oxygenation problem, if we fix it, we could get in a better spot. Is the mask and the pressures better tolerated when it's CPAP compared to BiPAP, or is it the same apparatus so it doesn't really matter?
It's generally the same apparatus. There might be some kids who are more bothered by the bi-level pressures. Most of the data in bronchiolitis specifically is that CPAP and high flow are non-inferior, so you're not necessarily escalating going from high flow to CPAP. And so in this case, you might need a little more.
And I do have a whole bunch of questions about ordering BiPAP, but let me just start with the first one, and then we'll kind of go from there. What should, we talked about what we shouldn't go over from an inspiratory peak pressure. what should we not go over from an expiratory peak pressure? Is there a PEEP that we shouldn't go above, and why or why not?
There's not a hard and fast rule for this. But what you have to realize is that there comes a point where you're using such high pressures that you're essentially using the BiPAP machine as a ventilator. And this is a kid who's acutely sick. So you might have a patient with horrible sleep apnea that sleeps on a expiratory pressure of 14. And that might be okay because we know that that's not a condition that's changing much night to night. But if now you have a patient who's day 2 of RSV and you have them on a expiratory pressure of 12 and an inspiratory pressure of 10, you're getting to a point where you're providing a lot of support, maybe even more than you would generally provide intubated. And then if you have to intubate that patient, you find yourself in a really risky intubation. So generally a PEEP or an EPAP of above 10 would really make me nervous and thinking about intubation in a broncholytic. And different people in different places have different levels of comfort with this, but that's about where I would lie.
And does that change by age, just out of curiosity too, how you feel about that?
Not really, with the caveat that small infants, I'm talking like less than 6 weeks, I just don't trust with bronchiolitis and they're going to cause problems. And so I would probably start to be concerned even before that 10.
Could you tell us a little bit more about that? I'm someone who finds neonates pretty challenging. I think their physiology is kind of like a little alien, but are there different considerations in the neonatal population?
So there's a few things. The first is that they're at higher risk of apnea. And so you're going to find yourself in a difficult position if they start to be completely apneic. The other is just a practicality, which is that you don't know these babies very well. And so children who are hospitalized before 6 weeks with bronchiolitis may be just normal kids who got unlucky, but they're definitely at a higher risk of having something else going on. Those are the kids that I look at a few times because why did they end up here so quickly? Is there something else that we may be missing? Is this not just run-of-the-mill bronchiolitis? And even if it is, they're young enough that they're at increased risk of bacterial infection and could always have a secondary bacterial infection.
All right, so I just have one final question about kind of BiPAP settings and choosing what we put people on. The interface, a lot of adults you see on full face mask, a lot of kids you see on the nasal portion. Can you kind of walk us through how you would choose between that kind of that RAM cannula you see in the NICU through the nasal apparatus all the way to a full face mask, and kind of what the indications are from that perspective?
Yeah, the interface you use is very important. So pediatric patients are all different sizes. They have all different face shapes. And it's important that the mask fit correctly and have as little leak as possible. So leak is air that the machine pushes out, but does not get back through the tubing. And that tells us that it's going out into the air and probably is not generating pressure in the way we want it to. As long as an interface can achieve a good seal, meaning not much leak, it can be effective. And so typically you have to try a few to figure out what works best for each patient. A RAM cannula can work in a very small infant if it's the right size. But pretty quickly, once kids are out of NICU size, it stops being effective. The other interfaces are full face masks. So it kind of looks like a hockey mask, covering your eyes, nose, and mouth. Tends to be easier to fit, but tends to be not greatly tolerated because children don't really like being in this sort of cage-like feel. There are other masks that can go just over one's nose. Those are often very well tolerated, but can be hard to get a good seal. And then over the mouth and nose. And so at your own institution, the respiratory therapist will know sort of what you have, and they'll be able to size them. But it's really important to find a nice mask with a seal, and then to be able to make sure that it's consistently tolerated.
This is a place where we're actively leaning on our respiratory therapists to know, they are fitting them. They know what's in the supply, what are, based on their experience, what works best for these patients, correct?
Correct. And this is a place where a lot of times emergency departments that have less experience with pediatrics will have a hard time because they, of course, don't have as many supplies. And so sometimes you have to be a bit creative. When you think about these masks, it's a good time to think about patients who should never be on NIV. And so patients who are fully apneic, those are not good patients to have on non-invasive ventilation. They need full respiratory support. Patients who are actively vomiting are not great patients to have on full face BiPAP because they're going to aspirate, you're blowing air down. So actively vomiting, GI bleeds. And then patients who are severely encephalopathic and not able to protect their airway are very high risk of aspiration. And so although it can be tempting to put a BiPAP mask on a patient who's seizing and just got a bunch of Ativan, it can often lead to a lot of complications.
So those patients are ones that you would like throw on highest flow, like standard nasal cannula while you prep them for intubation then?
Yeah, those are patients that I would move quickly towards intubation.
I've always been really thankful of respiratory therapists just because I feel like it gets confusing what masks to use, what not to use. So I'm always glad they're around. So kind of going back into our case again, how do you differentiate between a patient who still has a chance to improve on high flow nasal cannula versus one who might need immediate escalation, especially in relation to our patient ARIA?
Yeah, so the literature supports a median time of about 2 to 4 hours for improvement on high flow. So if you put someone onto high flow and your objective measures are about the same, I would give them at least 2 hours to show me that they can look a little better. And at the same time, I would make sure we control what we can in terms of treating fever and having good suctioning and saline nep routine. But looking the same is different than looking worse. So our patient, it looks like they're in front of us on a good amount of high flow and they're getting rapidly worse. In this patient, I wouldn't give them a lot of time. I would say they've failed this modality. They're getting worse in front of me on it. It's time to try something else. I feel the same way about severe hypoxia. So if a patient is on high flow and needing 60, 70% FiO2, that's someone who I would also immediately escalate.
And let's actually follow that up onto the BiPAP piece as well. How long are you putting someone on BiPAP? How often are you adjusting? How often are you checking blood gases, for example, to do that? Or are you doing it based on the exam that we're doing when we're talking about high flow nasal cannula, let's say on the inpatient floor?
Yeah, so this patient, hypoxia was one of our big concerns. If we put them on BiPAP and on a reasonable amount of FiO2, which we'll say something around 40%, their hypoxia is resolved and their work of breathing looks okay. I don't necessarily need a blood gas, but these respiratory patients are people that you're checking very frequently. And so circling back, checking, seeing are they better, worse, the same. And making sure you have good communication with your respiratory therapists and nurses so that everyone is on the same page about that assessment. In terms of changing the pressure on BiPAP, it's a little bit making sure you have your goals of volumes and then usually giving some time because the kids are going to get upset and agitated whenever you're in there messing with them. So they may need some time to sort of calm down so you can see what their exam is after the changes.
Yeah, tacking on to Sam's sort of question about BiPAP and monitoring, and obviously when we're talking about like hypoxic respiratory failure, we're talking like driving pressures and so forth, but also the FiO2. Are you flipping these folks onto like 100% FiO2 and then seeing how low you can get, and then is there a point where like the FiO2 is not getting to where you want it? It's like, oh, they're still riding like 90%. I'm not happy with this. We're going to have to maybe go to intubation, or is that also pretty fluid per patient?
I would say it's pretty fluid. In general, you want to switch someone when they're in a position that they don't need 100%. But you never know. This may be someone who just came up from the emergency department. You want to give them a chance to improve on non-invasive, but right now they need that. I tend to set timeline specific things there, and this is going to be my opinion. There's not going to be anything that says 65 minutes versus 85 minutes are going to make a difference. But I know that if I'm looking at someone and it's 2 a.m. and they're on 90% oxygen and in an hour they're still on more than 70% oxygen, it's very unlikely that this is someone who's going to do well without escalating to intubation. And so I don't think it's really important the actual numbers you set, but I think it is a little bit important to hold yourself accountable to them, because it's quite easy to just say, oh, they're kind of okay the same way they were an hour ago, and to realize that now you've let a night go by with a patient on settings that you would never think were acceptable long term.
Okay, so if we sort of step back a little bit, thinking about kind of my perspective as someone who sees, children who aren't very sick in the clinic, but maybe are at the beginning of bronchiolitis and could deteriorate. What do you think is useful in terms of counseling parents, like non-medical families, to look out for in terms of kind of return precautions and signs of respiratory distress?
Yeah, this is really important and a helpful thing for outpatient pediatricians to help out with. Babies are new to most parents, and they can be sort of mysterious. So I think when you're examining a baby, it's always good to talk through what you're looking at and point out things that are of concern. So people will often bring their kids in for fever or for runny nose. And so it's good to say, the kid has a runny nose, but look, I'm looking at the way they're breathing, and, their chest is rising, and you don't see a lot of their ribs or a lot of their stomach, and sort of pointing out where those areas where you would call them retractions would be. It's pretty easy for people to learn to count a respiratory rate, or at least guess a respiratory rate. And so that's often something you can teach parents, like to give you a rough guess of, even if they call you late on the phone. And then clearing the airway is really anxiety producing for new parents. So even using a bulb suction, really great thing to show them in the clinic, because often you can avoid an ED trip if you can just help them learn how to clear secretions from the nose.
So kind of going off of that, how do factors like access to healthcare or living in underserved areas impact how children with respiratory issues are treated and their chances of recovery, whether they have clinics available, whether they go straight to the emergency department? How does it change based on their access of healthcare?
This is a really interesting question. There's lots of research that shows that kids living in underserved areas and with high socioeconomic need have increased rates of bronchiolitis hospitalization, emergency department visits, increased severity of disease. And when you look at the Childhood Opportunity Index, lower COI is associated with higher bronchiolitis incidence, more severity, more PICU stays, and higher mortality rates. This general trend is true for asthma and respiratory illnesses. There's some evidence that smoking exposure and air pollution can play into this, but it's definitely not enough to fully explain the difference. And it is really an important area to better understand for these kids we take care of.
I actually had a follow-up question to that. I'm curious if prematurity actually plays a role in that, as we see also a similar, correlation with some of those things in patients who are born early.
Yeah, absolutely. And kids who are premature are at higher risk of respiratory illness in general. But even when adjusting for gestational age, there's still an increased risk.
No, very, very interesting. Awesome. Thank you.
All right. Well, as I think we're wrapping up now, I think I want to first thank you so much for spending so much time with us this evening. I definitely learned and relearned a whole bunch, definitely stuff that I haven't thought about in a while. So I really appreciate it. And I think a lot of our learners will really appreciate everything that you've talked about today. I want to ask, is there anything else that you want us to know about that from your vast experience of this? Otherwise, maybe just some of your take-home points for our listeners?
Sure. So I think the take-home points are that non-invasive ventilation is a great resource for preventing intubation and decompensation in patients with respiratory illness. And so if you work in a place where you take care of kids that are can present with bad bronchiolitis, you really want to know what resources you have. And then before you use non-invasive ventilation, you want to know what your goals are. So are you treating hypoxia? Are you treating hypercarbia? Are you treating both? And how will you know if your patient improves? And if you're treating tachypnea that's a little faster than you might feel comfortable, then that might be a patient that you actually can tell yourself, I might not need this. I might just need to be a little more comfortable.
Awesome. Well, thank you so much. I appreciate everything you've done for us tonight. Before we say goodbye, is there anything you'd like to plug? Are there any websites or resources or just cool things that you want our listeners to know about before we say goodbye?
You know what? The one thing I would say is the Open Pediatrics ventilator simulator is intended for invasive ventilation, but is actually a great tool. And sometimes you want to just say, if I were to play around with a ventilator, what would I see on a patient and how would I adjust it? And that's a really great tool for just sort of experimenting and learning to be more comfortable.
Oh, very cool. Yeah.
Very cool. I don't think we've heard that one before.
Yeah. This openpediatrics.org, is that this one?
Yeah, so Open Pediatrics, anyone with a medical email can register, but they have a ventilator simulator and a lot of other pediatric resources on there.
Wow, that's so cool. That sounds really fun as well to play around with that.
I definitely remember as a student just trying to understand like ventilation, oxygenation, tidal volume, and definitely when, talking about, invasive ventilation, just understanding all those types of modes, it seems like a good place to play around with that too, huh?
For sure. And it's a lot better, I think, to experiment on a robot patient than a real patient some of the time.
Absolutely. Well, thank you again for spending time with us tonight. Hopefully we can have you back.
Thanks so much. Had a great time.
This has been another episode of the Cribsiders.
It's for the kids.
It's for the kids.
Get show notes and sign up for our bi-weekly Knowledge Food Formula Feeds newsletter on our website at www.thecribsiders.com.
We're committed to providing you with high-value practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts, or contact us at thecribsiders@gmail.com. Special thanks to our producers, plural, for this show. That's Prachi Patel and Jennifer Chisholm, and our wonderful social media team, which is mostly Denise Cruz on X, Blue Sky, and Instagram. I've been Sam Mazer.
And I've been Jennifer.
And I've been Prachi.
And this has been Krista Chu Manchu. Thank you and good night. Jennifer, knock knock.
Who's them?
BiPAP.
BiPAP who?
By popular demand, we're adding pressure support. Prachi, knock knock.
Who's there?
FiO2.
FiO2 who?
FiO2, the rescue when sats are low. All right, I'm done.
That was not.
That last one was
bad. Yeah.
You
You should have quit while you were ahead.
Oh, yeah. Oh, well.
Yeah.
All right.